We'll go ahead and get started. My name is Madeline Russell. I'm project manager for SHIP that oversees the CHW initiative. Just a quick thing real fast. We have a CHW training that Bryant was talking about earlier. It's our last free training through ISU and the SHIP program. And it starts August 21st, so Tuesday, August 21st, and runs for 13 weeks. So if anybody's interested in that, we will have these paper applications to make the application process just a little bit easier. Back on our booth, it's the booth right behind the registration table. It's unmarked, so just to make it so easy. Anyway, so.
Is it online?
Yes, and there is the application online. And if you're interested. Yeah, sorry. Yeah, of course. The class is taught live online, so it's out of the comfort of your own home. You just sign in every Tuesday night from 6 to 9 and participate in the class that way. So.
And I guess this one with this I'm certified in Oregon, so I don't know
Correct.
if it's necessary for you to be certified in that.
It doesn't really certify that.
It's a completion. Yeah, certificate of completion. However, we are looking into the whole certification process. I mean, it is a process, and it takes a long time. So this is just the beginning of it, and there's the possibility of grandfathering the certificate of completions into that.
And it starts when?
It starts August 21st. Yes, and. So we do have a new process this time where we don't require an employer application. It's just the student application, so it's a little bit easier.
So how does that work with submitting data then?
Submitting the data, it's just we'll send you an email. It's every quarter after your course ends, and it's just there's 3 required measures that we ask you to collect, and then there's 4 additional measures. If you can collect more, the more the better.
From your work that you're currently employed at, or just?
Yes.
Okay.
Yeah, just what you're doing in that last quarter. Yeah.
Providing any additional information.
Correct. Yes.
How much longer do we do those for?
What do you mean?
The emails, like within the first cohort?
It's just 1 year. So you shouldn't be getting any more emails. Okay, another thing real quick, and you probably already heard this in the first breakout session, but we do have an evaluation form. And we will be collecting these after this breakout session. So please fill those out and then turn them in. There will be this manila envelope in the back. Just put them in there. It's all anonymous. So.
Can I do one for that? One I didn't get it. And I gave
You want?
they each have their own.
Yes. Well, there's 2 there.
So how many evenings is it?
The course? It is 13 weeks, every Tuesday night.
So 13.
13 weeks. Mm-hmm. Yep. All right. Well, and then I can, excuse me, I'll turn it over to Jayne Josephsen. She's doing the motivational interviewing for community health workers. And you can do, okay, I won't do the quick bio. It is in your program just to give you guys more time.
Let's see. You guys can hear me? Can you hear me? Yeah? Okay. So I'll give you a letter bio. So whoever was here earlier saw that the EDD stands for Doctorate in Education. And then a CCC-TM, I'm a Certified Care Coordination and Transition Management Nurse. And a CHSE is a Certified Healthcare Simulation Educator, and a CHPN is a Certified Hospice and Palliative Care Nurse. So that's all those letters. And that kind of tells you a little bit about me. And I am a professor in the School of Nursing at BSU. And I've done a lot of talks on motivational interviewing. In the past, before I went into nursing, I did social services and different kinds of social work things. Like a lot of like what you guys are doing, community health workers, but at the time they were called case managers years ago. Same thing, going into people's homes and kind of hooking them up with resources and things like that. So I've done that in the past, and that's kind of who I am. My specialty in nursing, for practicing nursing, is it started out in hospice, but the last probably 7 or 8 years, I've really been focused in clinical resource management. care transitions, different things like that, transitions between acute care and home care, hospice, different things like that. So that's kind of my background. But how many of you have been to training on motivational interviewing? Because I just was doing a webinar series on motivational interviewing that you guys have attended. So some of this may be repetitive, and so I'll just go through it quickly, which is what I suspected. But I asked Maddie, and she wasn't sure. So we'll go over some basics, just a little refresher. And then what I'd like to do for like the last half is do practice. Okay? So that's why you have the PowerPoint slide set. You can take that with you, review it at your leisure. If I go too fast through something, it'll be there for you to review later. You also have a packet of resources. Those are the ones that were on the SHIP website and a couple others that you can take with you and kind of keep with you when you're practicing your motivational interviewing techniques. And then the last one is an observational worksheet, because what I'd like to do after we go through kind of this overview is to have you guys practice in groups of 3 and have one person observe and do the observation sheet. Okay? So that's what the different pieces of paper are. And it'll be fun. You guys are like, it's going to be so much fun. You're going to be so excited. So you guys probably, since you're familiar with it, you've already done a lot of this. I'll just review it. Basically, we're going to go over the principles, processes, and spirits of motivational interviewing. Change process, really important, and some techniques of motivational interviewing. But my very favorite part really of this is to really learn some brief motivational interviewing frameworks, because all of us are on a time constraint, right? So we have to have something in our tool belt that we can pull out with our people that we're working with in a brief kind of way. Not a long, in-depth, counseling process kind of way. So we're going to examine some of those if you're not familiar with them. Okay, so basically, if you've gone through the training, you already know the webinar training that motivational interviewing is a conversation. And what I really liked about what our keynote speaker talked about was that it's a partnership, a relationship between you and the person you're working with. It's a process. It's a conversation. When I work with nursing students, sometimes talking about motivational interviewing, and other people too, they have a perception that it's something that you do. Like, I do it. I'm going to motivationally interview you. And then I'm done with it, right? I did it. I'm done with it. But it's not that way. It's a process. It's a conversation, just like building a relationship is. And I really liked how our keynote speaker brought that in, that is a really important aspect of the CHW role, and it's a very important aspect for motivational interviewing to be effective. Do you have to be a CHW to do this? No. Anybody can do this. Doctor, nurse, MA, CHW, receptionist, whoever is interacting with the person can integrate motivational interviewing into their interactions. So you don't have to have an EDD to do it. You don't have to, be certified in anything to do it. But you do probably need to practice it and kind of integrate it into how you interact with people. When I went to get my first degree in sociology years and years ago, one of the courses I took had us videotaped while we were counseling with someone. That was such a telling experience for me, because sometimes you think you're doing something. You think, oh, I am really interacting so wonderfully with this person. I'm really, meeting their needs. Then you watch yourself on tape and you're like, oh my gosh, did I really say that? As you're transcribing what you said to that person and how you interacted with them. Unfortunately, not everybody does that, and I'm not sure I'd promote it for everybody. It was actually kind of traumatic at the time. I was a very young person. But it is good to think about that the way you perceive yourself isn't always the way other people perceive you. So that's why you do need to practice motivational interviewing techniques. Even though you think you might have them under your belt, maybe you do, maybe you don't, but just kind of integrating that. The other big thing that I don't think the keynote speaker explicitly said this, but brought it up, is that the person is the expert on their own life. And we don't know their life. They don't know our life. I see that a lot in higher education. Students will talk to me about how busy they are and this and that and the other, but they don't think about that I have a life, that I have things going on in my life that may affect how I function. And so sometimes we have to really take that perspective of the other person, what is going on in their life. And he talked about that in the sense of kind of racial inequality and discrimination in different kind of groups. But I don't think it's limited to that. And the one thing that came to me when he was talking was about that we live in a very rural and frontier state. And that in itself can be a very disenfranchised, socially economic disadvantaged group. And so he kind of talked more about kind of maybe inner city groups, which I've worked with. I worked in Multnomah County in Portland, Oregon for several years, and there are a lot of inner city groups that have some serious issues there. I haven't really seen that inner city kind of issue stuff here in Idaho, but what I have seen is poverty and lack of access to care related to geographic location, related to socioeconomic status because of lack of employment and things like that. So I guess what I'd like to say is that, that person knows their life, and our job is to get to know what that is, not to make an assumption about it. And he talked about that. But that's a huge principle of motivational interviewing, is that they're the expert on themselves. That's a little different than the healthcare model that maybe we're used to, where somebody comes to the provider and the provider tells them, you're overweight and you need to lose weight, so go home and lose weight.
That works well.
But it is the model that we're used to. Isn't that the model that you see? Right? But they don't really take the time to get to know what's going on in that person's life. Maybe they are from a Hispanic culture that tortillas is a very, very integral part of their diet, and they're diabetic. So maybe we need to kind of think about that instead of just saying, cut your carbs. Right? So that might not be something that could really work for that person. So we need to think about that. And that's where the community health worker can really come in and make a huge difference, because you are that he talked about that link between the healthcare provider and the person. You're that community link. You understand the rural community. You understand the migrant farm workers community, or you understand the refugee community, or whatever community you're working in, where the provider doesn't take the time or have the time to really talk about those issues. So that's a huge thing. The spirit, and the biggest thing I really think about this, and again, I'm going through this quickly because most of you have gone through the training already. The biggest thing I think about this, the most important is, this word is weird. When I went over this PowerPoint slide set with my husband, he goes, "What is evocation?" And I said, it's a motivational interviewing word. But what it means is that we're really going to seek to bring out people's strengths. Everybody has strengths. Doesn't matter what they're doing, where they're at, even if they're an alcoholic or homeless or whatever, everybody has something positive to offer. And our job as a community health worker or any other kind of provider is to work to find that and evoke it, to elicit it, to bring it out, to bring it forth, so they can use it to make some changes in their lives. Sometimes people have been so oppressed or so downtrodden by different things happening in their lives, it's very difficult for them to even see anymore that they have something positive. And so we can really help them in the change process by kind of bringing that out for them. It can be small. It doesn't have to be some, huge, big deal. It can be a small thing, like, wow, you didn't take drugs today. That's awesome. I'm glad. Or you showed up at the homeless shelter on time so you could get a place to sleep. That's really great. It can start small. It doesn't have to be a huge thing. So I think that is the biggest part of the spirit of MI. I think the rest of them we often do anyhow. We are compassionate by virtue of our profession. We usually are pretty accepting of people, and we want to be in partnership with our people that we're working with. Okay, so the process. It's a pretty, I won't say simple process, but commonsensical process. But the biggest thing I want you to take away from this slide is that it's a process. So you can think about your own life. If you decided you needed to quit smoking, or pick something else, don't tell me what it is. Think about something you want to change in your life. You decided at this session right now you want to change it. And you're going to go home and change it tonight?
No, we're just thinking about it.
You're right. So no. And even if you decided you were going to change it, it's a process, right? So change is a process. It's just like this mountain is being created over time. So that is another thing in healthcare I see a lot. Is providers often get frustrated with their patients they're working with because they aren't changing. But we have to realize change is a process, and it can be overwhelming for people sometimes, and to respect that. It's overwhelming for us to change, and it certainly is no different for a person seeking health care. So in the process, we want to engage them. The keynote speaker really talked about that, building that trusting relationship. Clarifying, and this I think is important too. And I'll just talk about once we have that relationship and we're deciding we're going to clarify some priorities for change, we're going to clarify priorities for the person. So not our priorities, not the provider's priorities. Now, we may want to focus our conversation on, wow, you have diabetes. You know, what do you think would be the first thing you'd like to address with your diabetes? Would it be diet? Would it be exercise? Would it be your medications? Would it be skincare, going to the foot clinic? What would it be? Would it be quitting smoking? So we want to give them a voice in that, because when we're asking people to change, if we tell them, well, you need to quit smoking, you need to change your diet, you need to start exercising, and you need to start going to the foot clinic once a month. And those are all priorities. I'm not saying those aren't priorities for somebody with diabetes. It is. They all are. But the person hasn't agreed to it. It's not a priority for them. Is it going to happen? And then who gets frustrated? Everybody's frustrated, right? The patient doesn't want you to come into their house anymore. The provider's like, what are you doing? They're not changing. So we really want to make sure we've clarified that we're all in agreement on these priorities of change. Evoking, we already talked about. And then planning, that'll be making an action plan, which I'll talk a little bit more about in a minute. And then we can start all over. So we get the smoking taken care of. Then maybe we'll work on something else after that. That's another thing I think healthcare does a lot that doesn't support motivational interviewing, and that is they want to change too many things at one time. So, pick the priority, change that, and then pick the next priority. Okay, so that's kind of an overview of what motivational interviewing is. That conversation about change where the patient or the client is the expert, and in partnership we decide on priorities and make a plan. So let's talk about behavioral change just to review that a little bit. So you guys have probably seen this depiction that change is kind of a process, and I think you said you're just thinking about change, right? Right? So that's kind of the contemplation stage, right? I'm thinking about, well, maybe I need to change. Again, it's a process. I don't jump from I'm thinking about change to being able to maintain a change, in one day. It can take several months. It can take a year. It can take several years. I could make the change, and then I could relapse and have to go through it again, So just realizing that change is a process and it's contextual, and this is the part where the community health worker, I think, makes the biggest impact, is recognizing when you're participating in these motivational interviewing principles that you are part of the context of that person's life now once you've been accepted into that relationship. And so you really do have an impact on their change. Because change is contextual. It depends on their social support systems, their relationships, their characteristics, their lifestyle, beliefs they have. And you are in a great position if you have that relationship to really find out what those are and support change while addressing them in context. And that's something the provider necessarily doesn't do. This just goes over the different stages, and basically it's saying pre-contemplation, that's the first stage, and that actually means that they don't think they need to change. I'm sure you've met people like that. Contemplation means I think maybe I need to change, maybe I'd like to change, I'm thinking about it. Preparation is when I'm ready for change and I'm making a plan for it, but I haven't started my plan. I'm just making my plan. I'm talking with my CHW about what the priorities and goals are going to be and what the plan might look like. And then action is when I actually start putting my plan in place, and maintenance is that I've changed my behavior and I'm working at sustaining it. Okay, that's kind of the trajectory. But like I said, it could go back and forth and circular, and it's not linear necessarily. Okay, so before we move on to some actual strategies of motivational interviewing, I didn't want to go too fast, but most of you had gone through the training already, so the webinars. So do you kind of get an idea of what the motivational interviewing spirit process is and how the stages of change affect motivation? Motivation affects the stages of change? Or do you guys have questions? Nope. Okay, so we'll go on some strategies here. So the ORS tool, that is a really common strategy, and you see those two happy girls with their oars. They're so happy talking to each other. And that's because they're using open-ended questions with each other and really learning about what the other thinks about something. So an open-ended question's a question that isn't answered with a yes or a no or a very short response. Okay, so it's a question that elicits somebody's story, somebody's feelings, somebody's beliefs, or a statement, and we're pursuing getting to know what's going on. And we can focus in on whatever the behavior is, like diabetes management if we want to. A is for affirmation. Again, a big part of MI is to elicit strengths and resources, and affirmation is the same thing. You're affirming that the person is able to change, that they do have some resources to change, and that you understand that the struggles they have, that you can see their perspective of why they may be struggling with change. You're validating what's going on. I think that's something in healthcare we don't do enough of either. It's really validating that somebody may have serious difficulties with making a big change in their life, even if they want to. And really understanding why that's an issue and validating that, yeah, that is an issue. I can see why that's affecting your ability to change. Not that you still don't, not that I still don't want you to keep working towards change, but I can understand that that is an issue for you. Reflective listening, and that, again, is really trying to understand that person's perspective. So it's not just parroting back what somebody says, but thinking about that when you say something, like I'm talking right now, I'm coming from my perspective of doing counseling, going to school, being a nurse. I have all this stuff in my head, right? And it affects what comes out of my mouth. And it's the same with you or your patient or client or person, whatever you want to refer to them as. They have their own life, their own context, their own experience that affects what comes out of their mouth. And so we have to, when we reflectively listen, what we're really doing is trying to understand what they really mean by what they're saying. So we're not just parroting back, oh, you said X, Y, Z. That may be part of it, but what we want the person to know is that we really understood what they said to us. through that filter of their life experience. And especially with people that maybe don't have English as a first language, sometimes it's very difficult for them to express in English to someone what they're trying to say, because maybe there's not a word for what they're trying to say in their language, but there is in English, or vice versa, and that can be a real barrier. So reflective listening isn't just parroting, it's really trying to understand that person's perspective, what the message was that was intended to be sent to you, and letting them know that you understood it. What I heard you say was this. What I think you said was this. What I got about what you said is that you feel this way about something, right? And it gives them the opportunity to correct you if you did not interpret it correctly. Okay, summary. That's just good for all of us at the end of everything to provide a little summary, right? We want to summarize our conversation, what the plan is, what's next. I'm going to be here Friday at 2. We're going to talk about how your action plan went for the week. I heard in our conversation today that you had some issues with transportation and food. And so when I come back on Friday, this is what we're going to do, right? You're just wrapping it up in a nice little package, putting a bow on it. Okay. So we want to do that with our people all the time. Open-ended questions, affirmation, reflective listening, and summary. I'm going to skip that because we already talked about it. Okay. I'm just going to talk briefly about the types of talk, change talk, and sustained talk. Ambivalence just means a combination of change and sustained talk. Those are two motivational interviewing terms, which means change talk means they're talking about change, and sustained talk means they're talking about sustaining their behavior. So, and ambivalence means they're using both of them. And so a good acronym for this is the DARN CAT. DARN and CAT. So this is something when you're practicing motivational interviewing, you can use this DARN CAT acronym, put it in your tool belt and listen for it, because this is what's going to be telling you about whether your person's getting ready to change or not. Are they expressing that they have a desire to change? That's what D means, desire. Are they expressing they have the ability to change? Are they expressing reasons or concerns about their behavior, concerns about needing to change, concerns about their health condition? And needs. They're talking about how they need to change or they need to do something. So that's the DARN, desires, ability, reasons, and need. And so you can listen for that. CAT means commitment, activation, and taking steps. So this is something you can do when they're talking about this. You can elicit whether they're committed to it by saying, what do you intend to do about it? Not saying, this is what you should do about it. So you're telling me that you think you need to kind of maybe change your diet. So what do you think you're going to do about that this week? And let them tell you. Activating. What are they willing to do? Maybe they say, I don't know, it just seems, there's so many things, I don't know what to do, it's just kind of overwhelming. So we could kind of bring it down a little bit. Well, what would you be willing to do? What would be a small thing? What would be a first step? And then taking steps. And this one I think is really important. Eliciting what somebody's already done or what steps they already have in mind. I've worked with people before that you would think that they haven't done a darn thing to change their behavior. But then you talk to them, and they'll tell you that they did this, or they did that, or they did something else. None of them effective, none of them medically recommended, nothing you would say to them, you should do this. But in their mind, they see that as a way that they've tried to change their behavior. And that's okay. We need to know what they're trying, because if we don't know what they're trying already, how can we build on that? And maybe what they're trying already is the first step to something effective. Maybe they just need a little more motivation or a little more education about it. Okay. So barriers, I'll go over this briefly. I think the one that I think the most that we haven't talked about is if you did the webinar, you already heard this, but labeling our people as non-compliant. I think that is the biggest barrier to people changing. Even if you don't say it to them personally, if you have that attitude, people are not stupid, and they pick up on how you think about them. So if you think, oh, gosh, I got to go work with this person. I see it in nursing all the time. They try to shuffle patients around. Oh, I don't want to work with that patient. Let's give it to somebody else, right? And maybe community health workers are the same. I don't know. They don't want to work with this really difficult patient because they're non-compliant. So, and I'm not saying that people aren't difficult. What I'm saying is we just need to think about our perception. Why are they difficult? What's going on? Is there something going on that we don't know about? Is there some way we can address it? And is there a way that we can do it without a power differential? Because the thing about non-compliant, that word non-compliant, it insinuates that I have power over you. You are not compliant with me. I am in charge. You need to comply with what I say. So just think about that word. And especially when you're working with some disenfranchised populations, probably not the best approach. They've already been disenfranchised. They don't need to have it experienced again with their community health worker. So just something to think about. Are you communicating that even non-verbally? Or maybe you go back to the office and you start talking about the person in that kind of verbiage. Because really, if we're doing motivational interviewing, who's the expert? They are the expert. So we are partners in this. I'm not in charge. We're working together. It's a collaborative experience. So just something, I think that's the biggest thing I'd have you take away from this slide if you haven't thought about it before. Okay. Sustained talk is the same. The darn cat. And you can think about that again. It's the opposite of change, though. The desire is, I want to eat what I want. I want to do what I want to do. I've always smoked. I'm not going to change. I relax when I smoke. It helps me lose weight. I'm sure you guys can think of other things that you've heard people say. So that's sustained talk. And so we can think about how to address that. If somebody's in a sustained talk pattern, should we come in and say, oh, you need to not talk that way, we need to work on changing, or what should we do? Ask an open-ended question. Well, why don't you tell me more about that? Why do you think that? Right? And start a conversation. That's the first step, is starting the conversation. Okay. So this is what we're going to practice, and in 5 minutes, we're going to start our session. Brief motivational interviewing. So this just means that you're doing, this is one of them, elicit, provide, elicit. That means you're eliciting some information, you're providing some information, and you're eliciting some information. A big thing about motivational interviewing is that the person you're working with should do most of the talking. If I'm doing most of the talking, it's not motivational interviewing. So I want to find out, what do they know, what have they tried? So how much do you know about diabetes? They say, well, I know a little bit. Would it be okay if I provided you more information? So I'm not just assuming it's okay that I provide them information. I'm not plunking down papers and saying, we're going to go over this diabetic education today. I'm asking permission because that's polite. And we want to respect them and accept them. And then, so we go over some information, and then I'll elicit. So what do you think that might mean for you now that we've talked about wound care and diabetes? What do you think that might mean for you in your life? And then you can start talking about that. Well, it might mean I need to start going to the foot clinic. Well, yeah, that's a great idea. Let's get that set up. So, okay. Another aspect of change is to do a change readiness assessment. And that is pretty simple. This is in your packet too that I gave you resources. It's just basically asking somebody how important it is for them to make this change. If it's a 2, that's probably not a priority, right? So it's the same with confidence. How confident are you that you can change your diet or cut back on your tortillas? How confident are you about that? Well, I don't know. I like to have them about a 2, I think. Well, that's probably not the thing we need to focus on then. But we can ask them, what would make it go up a number? What would make you more confident? What would make it more important to you? And really kind of search that out with them. And then we can also make a brief action plan, which, you know, that's basically, which I'm sure you guys have in your workplaces already, some kind of care plan or something that you do with your person. But basically, you're just saying, you know, what do you want to work on this week for your health? Well, I want to work on walking 3 times. No, let's say I want to work on doing 80 sit-ups a day because I need to exercise, and I think that's what I'm going to do. So then I'm going to ask you, well, how confident are you, Jayne, that you can do 80 sit-ups a day? Well, maybe a 3. Okay, so then I'll have a conversation about, well, maybe what would bring that up to a 7 instead of a 3? Well, if I did 25 sit-ups a day. Okay, let's do 25 sit-ups a day. And that's your plan for the week. That's your brief action plan. And then when I come back on Friday, I'm going to check with you, or I'm going to call you, and I'm going to see how that went with you, you know, and we can talk about it again. So we wanted a specific, measurable, attainable, relevant, timely goal, right? Smart. You guys have all heard that before, I'm sure. Okay, but the important piece of that is this top part, follow-up. If we don't follow up, then we don't know how it went. So we need to follow up. How did it go with your plan? They had success. Yay, great. You know, let's do a new plan for next week. Partial success or no success. And then ask them, what would they like to do next? And really put it in their control. This last little table just talks about if they're doing well on something, sometimes, especially like with smoking or alcohol or substance abuse or even eating, sometimes things trigger a behavior. And so if somebody's working on changing a behavior that has triggers, we do need to work with them on a coping plan. Like, how are they going to cope with that trigger when it happens? You know, whenever my brother-in-law comes over, he offers me a joint. And, you know, he lives next door to me. So then we have to talk about that. Like, how are you going to deal with that? Because he's probably still going to come over and offer you a joint. So, you know, or are you going to say you can't come over? Or what are we going to do? So that's just kind of that strategy. Okay, now we're going to do our role play. So what I'd like you guys to do is break up in groups of 3. And you guys have on your handout your role-playing scenarios. You can pick one in your group, whichever one you want. I don't care. I would like one person to be the client, person, patient, whatever you refer to them as. One person to be the community health worker, and one person to observe. Now, I gave you a sheet where you can, I have this microphone. I gave you a sheet where you can observe the person doing motivational interviewing. That means practicing the oars, right? Practicing being, evoking strengths, practicing being accepting, practicing acknowledging the client as an expert. And the person observing can kind of tick off how many open questions, how many closed questions, how many reflective statements, how many affirming statements, how many summaries, empathy and understanding, okay? So do you need help breaking up in your groups of 3 or so? If we have an uneven number, we can have a group of 4. Okay. So there's a group back here of 2, right? So they need a partner. We've got group 3, group of 3, group of 3, group of 3. So why don't you 2 go back with those 2? And we'll have one group of 4. Okay, and so we're going to do this about, I'm going to say at least 10 to 15 minutes. At least 10 minutes.
Well, then that means you got to be the one to do it.
I asked him to pose them the question, and as soon as I asked him,
So should we start from the top and go down? Who wants to be the one? You need to practice.
Just pick one. It doesn't matter which one you pick.
I'll be a patient. It's 34-year-old policeman. Oh, it doesn't say male. Anyway. Oh, 6-pack beer.
And we'll switch at 5 minutes so one other person can have an opportunity.
All right.
5 minutes.
okay. Okay. Are you gonna try to close stuff? Hi Mark. I'm Cynthia.
Hi, Cynthia.
What brings you to the clinic today?
I can't sleep. And my wife's about ready to divorce me because when I can't sleep, I get mean.
Oh no, I'm sorry to hear that.
Or you can think of one on your own.
So you can't just give your divorce.
No, we're not getting a divorce. I'm trying to prevent the divorce by being able to sleep.
Oh, okay. All right. Well, why is it that you're not able to sleep, or what?
I just can't sleep.
You just can't sleep.
I go to sleep, I fall asleep pretty fast, and in 2 or 3 hours I wake up and I can't go back to sleep.
Okay. What are some things that you've tried to help?
Well, my wife has a CPAP, this prescription sleep aid CPAP, so I've been trying that, but it doesn't do any good. It doesn't help.
Okay.
This just makes her so she can't sleep now.
Oh,
So she started to use it. So I've given it back to her.
you're back to her, and you're still unable to sleep.
Yeah, it doesn't help at all.
Have you tried going to see a doctor about this? Is that why you're here today?
Yeah, they said they gave me some prescription medicine, and that really didn't help either. And then they've tried sleep with your head elevated. That didn't help. You know, it's the same problem. Go to sleep fast and wake up.
I don't know, Mark. You don't think.
Well, it says something about 6-pack beer.
Okay.
So maybe an open-ended question would be, so tell me what you do in the evening before you.
So, Mark, why don't you tell me a little bit about your daily routine? What do you do during the day, and what do you do during the evening?
Well, I'm a police officer, so I'm stopping people at traffic lights and investigating things, and it's always like, am I going to get shot when I walk up there? So by the time the day's over, I'm just a nervous wreck. So I go home and we eat and we watch TV, and while I'm watching TV to relax, I drink a little beer.
You drink a little beer, and does that seem to help you?
Oh, it puts me right to sleep.
You're right to sleep.
So I don't understand though why. Then I wake up.
I don't know what to say here. I mean, I know what to say, but it's not open-ended.
Well, I say a little beer. How much beer is it?
Well, how much beer do you drink?
Oh, about a case every. I'm in a 6-pack. A case. That's about a case every night.
About a case every night? Okay. And how does that make you feel aside from sleeping and then...
Well, it makes me really relaxed, and it makes me say, I'm really not thinking about the problems from the day.
Okay.
But then I go to, and like I say, it lets me sleep. Sometimes I fall asleep on the couch. I fall asleep so fast. but then I just wake up around 3 and don't go back to sleep.
Okay. Do you think that maybe drinking a six-pack affects your sleep in a way where it makes you wake up at night?
Well, no one's ever told me that. I mean, I've always just, thought that, it just relaxes people. Is that what it does? Does it have other impacts other than relaxing you so you go sleep fast?
I don't know, or reading a lot of
I've never had anybody that's drinking. So you can what do you know about it? And so if you felt like you weren't able to give them that information, you could find out from your notes, and then you could go get that information at your clinic and ask them if it's okay that you bring that back to them at your next meeting.
I would have handled that differently. You would have been like, this is what happened to your body. I mean, then I draw a little diagram.
If you felt like it was out of your scope for you.
Is it within their scope though?
We do some teaching, but it just depends on, like, I know we get training for tobacco cessation training, so we do some sort of motivational.
It would seem like if you know how alcohol impacts your body, you'd be able to
Well,
talk
no,
about it.
not necessarily outside my scope, but outside of the motivational interviewing process, because I wanted to jump in and be like, well, actually, Mark, it does affect you because this is, I don't know if that's.
So you could do that after he gave you permission, which he did.
Oh, okay. All right, Mark. Well, actually, I do know a little bit about the effects of alcohol in the body, and most people do think that alcohol relaxes you and helps you go to sleep. But actually, alcohol, it actually does not help you sleep or have a restful sleep, which is why many people will wake up really early, earlier than expected, and which may be why you are possibly waking up in the middle of the night and unable to go back to sleep.
So I have a couple questions.
Okay, so let's wrap up this person and rotate. Let somebody else have
What my questions would be, so
Yes.
how long would it
Yes.
take if I did try not drinking, how long would it take before I would see impact?
And you can pick a
What
new
would I
role
expect?
if you want, or
And
you
the other
can
one
use
is,
the same one.
how do I relax without my alcohol?
Yeah,
I mean,
we're gonna
that's
rotate.
I mean, it gets me out of my crisis mode that I've been in all day. So,
And then that's for you to see it.
chasing those young men over the fences when they're running from me gives me lots of pain.
Yeah. But usually it's when, like, for me, I usually just when I tell myself, I haven't had to say it, but I will say, like, exercising, maybe running, jumping around.
I don't know, dopamine I don't know if that's meant to go to sleep, but endorphins. Yeah. Anyway.
Alright.
And you guys can pick your own client, or if you know someone, it doesn't have to be off the sheet, or you can be yourself even. Doesn't matter.
I'll be Julie.
So is Julie's the next one? Oh, yeah, I'll ask questions.
Okay.
Let's see, you're.
Oh, it's right here. I didn't understand how to do it. I'm also sleepy.
You need a new sheet.
I didn't know how to do it.
Okay.
Chocolate on it.
That's okay. So when you listen to him, you'll get because he's the CHW.
Yeah.
Okay. So if he does an opening question, like ticket, if he does a closed, okay, ticket. If he does a affirmative statement, a reflection, we take that.
Hey Julie, thanks for meeting with me. Your doctor referred me to you, and I just want to know how you've been feeling lately.
Well, I've been feeling pretty tired. I'm sleepy a lot, and I get really hungry. And there's the times that I'm hungry, but then I go eat. Then I'm craving it, then I see the food and I
Usually what we get is
So, what are you craving? What do you want to go eat?
I really want my like fast food, but I know I'm a diabetic. My I don't have time to be cooking. It's only me at home, so I really don't want to spend other money grocery shopping. Because I just spend I tried eating healthy though.
So, how do you equate McDonald's and healthy eating?
I tried driving a salad, or instead of getting the Big Mac combo, I tried half a meal, but I still have some maintain others, so I can give myself I'm a type 2, so I can take my medicine.
Do you know by chance what your last set of metrics were as far whether related to your diabetes?
Oh, my hemoglobin A1C. Yeah, it was an 8.4.
Maybe 4, and you eat a lot of salads?
I tried to eat out salad. I really don't like them.
How's your exercise?
Well, sometimes I do, and sometimes I don't because I'm tired. And I work all day and I'm walking, so I figured that's enough exercise.
Do you know how far you walk?
Not really. I just got this really cool pedometer. And next week I'm going to start using it on Monday.
Next week, do you have someone else that you could team up and you guys can talk about this when you're at the end of the day, how far you compare, how far you walk?
No, I don't. I don't have a lot of friends. I just try to stay to myself, or I'm always trying
So, get your life together, everybody.
Hey, this is my patients every day.
Why don't you start with your pedometer now instead of waiting for a week?
I was just thinking I'd start on Monday. I figured I'd start from Monday to Friday. I don't want to start on Monday.
So we're going to wrap it. What did you guys think about that? What he just asked?
Do it because I want to.
So, yeah, so how would your person you're working with probably react to that?
It's like, what is she doing?
I just want to say,
Whatever.
what's the difference between Monday and Wednesday?
Yeah, but wait until Monday.
If it's like Monday afternoon, it's like, oh, I'm going
I have to wait next
Monday.
Monday.
So, okay, let's wrap it up. We only got about 6 more minutes. Let's wrap it up. I hope you guys got a little taste of thinking about how you're asking questions. I mean, you're not going to be expert in 10 minutes, but
It was hard.
okay, I should put my microphone back on. There we go. Okay, so can we, you guys can just sit where you are because we only just have a few minutes left, but maybe would 1 or 2 groups kind of talk about that experience of kind of observing somebody and, how many closed questions versus open questions did you see? Was it easy? Was it hard? What do you guys think? Yes? Okay. Body language, yes.
Well, in our scenario, Robin was the interviewer, and Nebras was the interviewee. And I noticed in their conversation that Robin asked initially more open-ended questions.
Okay.
And then after she kind of established what challenges she was having, then she asked more closed questions.
Oh, okay.
It wasn't a matter of I thought at first that she was going to ask maybe twice as many open questions as closed, but that wasn't the case. She just asked all of her open questions first so she could get all of her information.
Okay, and then transition to closed. Okay. That's a really interesting observation. So what do you guys think about that in motivational interviewing?
I don't know about motivational interviewing, but just right now, it was kind of easy to get a few open-ended questions out, and then it just kept narrowing down to where I felt forced to start asking pointed questions.
Okay.
And so maybe it wasn't because of the information, it's because how do I ask this open now?
So I think that's a really great point. I have this cord. I think that's a really great point. And I also heard some people giving advice. So where does that fit into motivational interviewing?
Do you think maybe it depends on who you're interviewing?
No.
No, not at all. A 83-year-old woman who is very forgetful and can't remember anything is a whole lot different than somebody who's going to be able to give you some.
So a big tenet of motivational interviewing is that the person's the expert, and that if you do give them advice, what do you do first? You ask them for permission to give some advice. Would you like to hear what I think about what's going on? And if they say no, I don't care what Jayne thinks, then Jayne keeps her thoughts to herself. Because it's really about meeting that person where they're at. So I did hear some advice giving. And I think that in healthcare, I think closed-ended questions is what we're used to. We have our checklists but in motivational interviewing, there should be few closed-ended questions, because what we're really trying to do is, instead of giving advice, what are we really trying to do?
Encourage change.
Have them find
Have them find the
the solution.
solution, evoke their strengths and resources, have them feel that they can make their own change, and have them decide on how they're going to make their change. And then we support them in that process, right? And so there should be few closed-ended questions, few. I mean, I know sometimes you have to, like what's your birth date, to confirm somebody who they are and that sort of thing. But if you're doing a motivational interviewing session, it would be pretty few. Yes?
In a successful motivational interviewing session where you do come to a complete close, how would you end it? Would you end it like how can I help you, or how?
So you would end it with the summary. Okay. You'd end it with the summary. So today, you'd reflect what happened in your session with them, talk about what the next steps were, make sure you're all in agreement.
Okay.
Yeah. And then if you're not going to see them again, then you might say, and here's my contact information or whatever. Yeah.
How do you guide them if they to coming up to their own solution if they don't understand the mechanics or understand what the correct solution is? I mean,
that's interesting. What is the correct solution?
Well, if it's diabetes and you're eating too much sugars, I guess stop eating sugar.
But what is the real correct solution?
Getting them to stop eating sugar.
What works for them. Yes, that is the real correct solution. So I may think as a healthcare professional that you need to do X, Y, and Z, and maybe according to research, you do. But if that doesn't work for that person in their life, that's not the correct solution. So that's why we really have to get to know what their life is and ask and develop that relationship so we can introduce some education about whatever's going on. Maybe over time they will move towards embracing a more traditional solution, but sometimes people are just going to have their own solution that isn't going to, I'm going to look at it and go, yeah, I would not do that. But it's not me, is it?
When you try telling a provider that, they're like, oh, well, what did you do to them? Or why aren't they changing? It doesn't happen overnight.
It doesn't.
I've been working with patients for 4 years, and guess what? I'm finally starting to see the change from 4 years later. And they're like, well, you should be doing your job a little bit better.
And you can show them the slide set.
No, I know. That's what we think, because we're used to now, I want to change now.
Yeah.
But if they're not ready, they're never going to do it. So
yeah.
little by little, look at it.
Yep. So I have like 1 minute left, and there's two things I want to say. This is on the front of your handout. This is something you can take with you. This is another acronym. Motivational interviewing has a ton of acronyms for those people who like that. So this is one you can take with you, and I think it's really important for healthcare. And the first one, R, means resist the writing reflex, which is just what we talked about, right? I'm right. I'm telling you what you need to do. I have a doctorate in education. I know what you need to do about your diabetes, right? Okay, maybe I do, but if that doesn't work for that person, it's not effective. Okay, you guys can look at that in your handout packet. And then this one I think is very important, this last thing I'm going to say. If you're feeling like you're having a power struggle, you're going around in circles in a conversation, you are butting heads, however you want to phrase it, then you're not doing motivational interviewing. Okay, so if that's where you're at, that's where you've arrived, it's time to step back, maybe come back to the next session, summarize, take a break, whatever you need to do. A phrase of motivational interviewing is that you should dance with the person, not wrestle. So if you're feeling like you're wrestling, you are not doing motivational interviewing. And that's when you need to take a break and come back to it. Okay, and so that is the end of our time. I do want you guys just to know that I did put a lot of different handouts in this with little different things you can cut out. They're all available on the web. You could laminate them, put them in your notebooks when you go see patients, right? Different things, the rule, ORs, different change talk things. So lots of different resources for you. This is a handout that says, am I doing it right? Motivational interviewing. You know, it has a checklist of 12 points you should be doing. So all these things, they're available on the web. You can print them out, laminate them. There's some action plans, forms for making an action plan with your person. So just so you know, there's lots of different resources in here, and you are welcome to share them with your providers who may think it's an instant change. And there's lots of website and book resources on the back, too. Okay? All right. Thanks, guys.